Okay, everybody, should we make a start? I think it's fair to say that some people might join us later, so we can catch them up as we go. Just to say welcome to everybody. It's quite exciting to be able to bring something new and hopefully very positive in an otherwise quite confusing time. So this hopefully is quite exciting for everybody. Just to say, normal kind of meeting etiquette, if you can. There might be a few of us on the call, so cameras off and on mute if you're not speaking. Whilst we're going through questions, if you pop those in the chat, and we've got Q&A at the end, and then obviously hands raised as well. We'll have a look at those, but we'll try and save everything for the end if we can. Already slightly mentioned it, but just for anyone joining later, if you can keep the name of the practice that you're representing in the chat somewhere, we're going to use that to collate the attendances today. And as ever, these things are being recorded, so just so you know, it will be recorded and made available on the website later, along with all of the other kind of information that we've got going for the project. So just to introduce everybody, so I'm Carl, I'm the Borough long-term conditions lead with CCG, but I'm also a GP at Marlborough practice. To introduce Priscilla, who's here from Independent Clinical Services, to tell us more about their project. Eva is going to help us with the medicines changes, and Claire from the CCG, who's been organising everything. So here's a little rough breakdown of what we're going to go through. There is a huge amount to go through, especially in some of the finer details of, and I'm sure some of the things that I focused on, and maybe others will too, on things like medication changes and the inclusion criteria. There's quite a lot on some of these slides, which is why we're deliberately sharing them, going to be putting them on the website. But again, all of the kind of resources should be there. And there's things within EMIS as well that kind of guide us as we go through. So hopefully it's all pretty clear. Okay, so I think, Claire, you're going to start us off.
Thanks, Carl. Hi, everybody. Yes, I'm just going to give you a bit of background to the programme and how it's come about. So the service has been commissioned by NHS England. It is a pilot for 2 years. NCL CCG, we are one of 10 different pilots across England, and we've been allocated 500 patient places across the patch to take part over that 2-year period. So the programme itself is based on successful clinical trials called Direct and Droplets, which found that patients with type 2 diabetes who were overweight, some of those patients achieved remission of their diabetes as a result of a low-calorie diet treatment, which is very positive, and that sort of set the foundation for this pilot, for this service. The service itself will be delivered by Independent Clinical Services, otherwise known as ICS. They also provide our diabetes prevention programme, so we already know them quite well. And just to flag that the service will be provided digitally, so it's all done via an app and phone calls with the patient, but Priscilla will provide a lot more detail around that in a moment. Just to flag as well that there's no cost for the patient, and we thought that might be a question that came up, and that there will be a full evaluation of the service by NHS England at the end of the 2-year pilot period, and we'll take it from there. Hopefully, if successful, will be rolled out nationally. So just to cover a few aims of the service, we're hoping to see for patients a reduction in their weight and a maintenance of that weight loss, a reduction in their 3 treatment targets, so HbA1c, blood pressure and cholesterol, a reduction in patients' medication usage, and for some patients even a remission of their type 2 diabetes, which is obviously the best possible outcome. So for the purposes of the pilot, remission has been defined as a HbA1c of less than 48 millimoles per mole. That has to be maintained for at least 6 months, and the patient for the patient not to be on any glucose lowering agents. And we'll provide full details of how patient milestones and outcomes are communicated from ICS back to the practice later on. So I'm going to hand over to Priscilla to give a full overview of the service and what ICS will be offering.
Thank you, Claire. So my name is Priscilla Brage, and I am the Contract Liaison Officer for the NCL area. And so I work with ICS Health and Wellbeing. And so today I'm also joined on the call with Naomi Jones, and she's the LCD Operations Manager for ICS. Now, just to give you a little bit of a background on who we are as a service provider and how we've come to deliver the LCD pilot. So some of you may be familiar with us already, as we are the providers for the NDPP program across NCL. So what this means is that we are already established and we do have a good understanding of the local needs of North Central London. Now, we've also delivered other programs with the aim of remission. Now, we've delivered an LCD pilot across Hammersmith and Fulham, and also in a practice in Enfield, and this was a one-to-one dietitian-led program. And now, what you see here in this slide are the outcomes that we've seen from this pilot. So after 12 weeks, there was an average weight loss of 13.5 kilos, and then there was a HbA1c reduction of 13 millimoles per mole. Now, more recently, we've also been commissioned by Northwest London to deliver the Rewind program. And this is also a TDR program, but this is group-based. Now, these findings and all of our experience, they really have supported us in our learning, and it really does provide us with a really good framework for a successful delivery here in North Central London. Now, in addition to NCL, we've also been awarded contracts in 4 other pilot areas, one of those being Northeast London. So, you know, what we're planning on doing is just taking all of the information and learning from all the other areas, and really do want to provide just the best delivery possible for this area. Next slide, please. So before I go into detail about the program, what I wanted to share with you was the video that we do provide to the patients once they're onboarded, and it concisely describes the overall program. So hopefully everyone will be able to hear the audio as it does play. Wonderful. Thank you for that. So hopefully that video really does give you a good overview of the program and the support that's available to your patients. Now let's talk about who can actually join the program. So I won't go over this slide in too much detail, as I know it's being covered in other sections, but the main point I really do want to drive home is that the eligibility and the exclusion criteria has been set by NHS England to ensure patient safety. Now, on this program, patients will be coming off medications and they will be experiencing a significant reduction in energy intake. So their safety really is at the forefront of everything that we're doing. Now, you'll notice that in order to be eligible for this program, the patient should be first 18 to 65 years old, diagnosed with type 2 diabetes within the last 6 years. And their BMI should be at least 27, but it can be adjusted down to 25 based on ethnic origin. Now, it's also important that the patient have attended a review within the last 12 months, and with that have gotten an HbA1c measurement of at least 43 or 48, and that's just dependent upon if the patient is on diabetes medications or not. But in both scenarios, whether on medication or not, their level should be no greater than 87. And then in addition to the review, it's also important that a retinal screening has also been performed within the last 12 months. Now, on the right side of the screen, you'll notice that these are the exclusions. Then that's the full list there, but also know that the exclusions are also listed on your referral form. And then we will also do an additional screening once we've received the referral form from you, just to double check that the patient really is safe to proceed on with the program. Next slide, please. Now, this slide is really important to help you understand the patient's journey from the time you refer a patient up to the point to where the patient starts the program with us. So if you're looking at the left, it begins by you making and checking the eligibility of the patient just to make sure that you find the suitable candidates. And so you might do this through a clinical search or even might having prior knowledge of some of your patients. So when you start by making the referral, it's really important to gauge your patient's motivation and their commitment just to ensure that this program is a really good fit for them. Now, we know that a major component of this program is having the patient replace all their meals with soups and shakes for 12 weeks. So we understand that it may not be a suitable program for everyone. So it's really important that the patient's motivation and their ability to commit all of that, you do all of that assessment before referring them onto the program. Now, once you are confident that you found a suitable candidate for the program, you will then complete that referral form, and that's embedded within your clinical system. Now, part of the referral form, once you've sent that through, we will also receive notifications of those medication changes that you've attached to it. And those medication changes will be enacted on the first day of the TDR start. And it's also really important that the patient receives a copy of those medication changes. And once it's sent through, we do a double check of their eligibility and just make sure that the patient is ready and motivated and that they do understand all aspects of the program. And we will also verify that the patient has received a copy of their med changes. And if for any reason we find that they haven't, then we would need to put them on pause, and then we would direct them back to you just to make sure that they are able to receive the medication changes, because that's a very important bit of information that they need to know as well as understand. Now, we're just assuming that everything goes well and that we've confirmed that the patient is eligible and they have a copy of the medication changes as well as us. Then the patient will then just be booked onto their initial assessment, and then we will schedule them for their digital review calls as well as schedule them and we will just agree on their TDR start date. Now, at the initial assessment, that's the time that we use just to better understand the patient's needs. And during that time, we'll set goals with them as well as get them set up on the app. Now, we will also issue them a free code just to order their self-monitoring kit and all their TDR products. Now, on the day that they are scheduled to commence beginning the total diet replacement products, that we will contact them again just to confirm that they have actually enacted the required medication changes, and just also be there just to answer any questions for them. Now, as I mentioned before, it's really important that they do come off their medication, because if they haven't and they actually do start the TDR products, then that's actually not safe for them to do so. So if we ever do discover that this is the case where they haven't stopped their meds, then we would connect back in with their healthcare provider just to make sure that we can actually proceed with this patient. Now, with all of this process, it might seem quite involved, but I hope it does convey that the patient is well supported, and then that we have placed many checks in place just to ensure that the patient will start the program safely. Next slide, please. Now, in addition to the eligibility criteria, it's going to be really useful if you understand the program as a whole, just to help assess the patient to see if it's suitable for them. So in summary, this is a 12-month digital program, and it's delivered by our diabetes practitioners, and they're trained to deliver this remotely. Now, the service users, they will have 15 one-to-one review calls with our team, and it's there for as a support. And we place these throughout the program in a way that is just relevant to where they are in the actual program. Now, beyond the one-to-one calls, they also have the ability within the app to chat directly with our diabetes practitioners. And there's also a range of resources within the app that they can use, such as the community forum, and that allows them to engage with other peers who's on the program. And then we also provide 26 online e-learning modules for them. And once again, those are unlocked at various points based on their progression within the program. Next slide, please. Now, this video is really nice as it gives you a summary of the program as a visual representation of the patient's journey. Now, after the initial assessment, the first 12 weeks is where the patient, they'll stop all the normal food, as I stated before, and those will be replaced by 4 TDR products, which can be a combination of soups and shakes, and these provide about 800 calories a day. Now, the learning and support provided during this stage will be around supporting their motivation, and as well as applying behavior change techniques just to ensure that the individual can sustain their meal replacement period. Now, stage 2, this is the food reintroduction phase. And this is a 4-week period where meals are introduced once per week, just until they're back on a healthy, balanced diet. Now, the education that we provide during this period, this promotes a positive outlook on food, as well as supporting all the individuals just to understand what a healthy and balanced lifestyle looks like for them. Now, stage 3 is the maintenance phase, and this is where they are now fully back on a healthy, balanced diet, and the focus during this period will be on ways around managing the weight that's beyond the total diet replacement products. So that's when we look at things such as physical activity and calorie management, just to help them maintain all the weight loss that they've achieved during the TDR phase. And lastly, we like to finish up at week 52 with a final assessment, and that's where we celebrate their success. And then we look at identifying areas of support for them beyond our program. And so we do this by signposting them onto other services, as well as just connecting them with other local resources. Next slide, please. Now, this slide is here just to provide a bit more detail as to the expected calorie allotment and what each week looks like as the patient is transitioning through the food reintroduction phase. So we found that this part of the journey, stage 2 at the food reintroduction phase, can be quite challenging for many because that's where they're beginning to make decisions on what to incorporate back into their diet. So this has been included just for your awareness in case you have any discussions with your patients. And then we've also included some of their top tips that we found useful during each of the 3 stages. Next slide, please. Now, this slide just provides you with some of the screenshots of the app's functionality. So the patients, they'll have access to the 26 online learning modules, and those will be unlocked at various points. They will also have information on all of their upcoming sessions, and these will act as session reminders, providing them with the dates and the times. We also have a health tracker function, and this will allow them to enter all of their measurements as they are self-monitoring. And this will also allow us to carefully monitor their journey as well as their results. We also have a coach chat function, which will give them the ability to chat directly with their diabetes practitioners. And then they can also engage with other peers on the program, and find, that additional support from maybe someone that is a bit further down in the program through the community chat forum. Next slide, please. Now, all of our TDR products are supplied through Ultralife, and the products do provide all of the nutrients that are necessary for them while they're on that 12-week total TDR phase. They do consume 4 products per day, and those are available in a range of flavors. So those are available, the 4 shakes are available in chocolate, strawberry, vanilla, and banana. And there are 2 soup flavors, vegetable soup and chicken soup. All the products are halal, they're kosher, and they're gluten-free, and all of them are vegetarian except that chicken soup. So you'll see that it really does provide a nice wide range of, it does meet those cultural and dietary requirements of a nice range of people. Now, it's also really important that I wanted to note that we do try to support them at the start of the program, and we do this by providing them with a sample pack, and that includes all the products so they have the ability to taste all the products first, just so that they're able to then pick their favorites so that they have those during those 12-week phase. Next slide, please. So as I mentioned before, at the start of the program, we'll be providing the patients with all their self-monitoring kits. And so that includes a scale, a glucometer, and we'll be providing them with also enough supplies to sustain them during the 12 months. And then also if a patient does require to have their blood pressure monitored, we'll be providing them with a blood pressure machine. And so this just allows them the ability to self-monitor at home, and then we'll be collecting all of these measurements at different points, and they'll also have that ability to enter all of the measurements through the app. Next slide, please. So this slide is here just to provide some reassurance around any concerns you might have regarding any potential queries that might come up. And you might be feeling that they might come back to the practices just based on use of equipment. So this actually, we hope this isn't the case, because we will be providing all the individuals with videos and guidance documents. And then they'll also have the support of their diabetes practitioners to help them understand how to use the equipment and how to monitor their blood glucose and blood pressure. But if you are finding that you are getting patients coming back to you with these queries, please do let us know, and then we can try to field all those for you. Next slide, please. Now, in terms of adverse events, from the direct and the droplet studies, and even from our own pilot, we know that there are occasional side effects of the TDR phase because they are on an extreme calorie deficit. Now, the most common of those are headaches, fatigue, and constipation. So we do have our diabetes practitioners, and they have been trained to help them manage all of this, but then we also have a multidisciplinary team, and they'll be there to help support any high-risk individuals if there's something that comes up that needs to be monitored more closely. Now, one other thing I wanted to mention is that in terms of combating some of those side effects, we do provide all the individuals with fiber supplements. So hopefully that will reduce the impact of constipation while they're on the TDR phase. Now, I mentioned our MDT team, and so they'll be there just to manage all of these aspects of the adverse events and such. And if we do find that there's any situations that require further medical attention, they will be in contact with the GPs just to assess if it really is safe for practices to continue on based on certain criteria. And those I'll go over now in the next slide, please. Now, just to highlight some of the key parameters that we're looking out for. So we will be monitoring any excessive weight, loss. So if the BMI of the patients drops below 21, then we would actually look to have them stop all the TDR products, and then we would transition them onto the weight maintenance phase. So of course, they can continue on with the program, but we will just be monitoring their calorie intake really closely just to ensure that they don't continue to lose weight. Now, regarding their blood glucose and their blood pressure, NHS England has outlined the acceptable range, and so that's what we'll be working with. But if we find that there are any individuals that drops outside of those ranges, it will be reviewed by our MDT team, and then if required, we'll connect back with their clinician just to discuss the next steps for the patient. Next slide, please. Now, finally, just to touch on some of our additional features. So all the patients will receive a hard copy of their personalized action plan. So even though this is a digital service, we will provide some hard copy resources to them just to provide that additional support and reading for them. Now, in addition to the app resources, all the service users will also have access to the desktop version, and this will have various recipes, tips, and then these can be shared with their friends and family just to help them and provide another layer of support for them. Now, hopefully, just everything that I've gone through, it really does provide you with a really good overview of the program, and as well as the support that we do provide to the patients. But if you do have additional questions, or if you've had questions coming through, I'll answer those in the chat, keep them coming through the chat, and then I'll also be available at the end of the session for Q&A. Thank you.
Okie dokie. So coming on to selecting and then inviting eligible patients, there's already a EMIS search, so that should be in every practice through the rollout, and that will help just to identify a cohort of people. We're obviously dealing with quite small numbers per practice, and when we've been discussing with some other national clinical leads across the pilots that are happening, it seems to me that quite a lot of the value in choosing and discussing the program with appropriate patients is going to be based on your personal knowledge of the person. So we do think that it's probably better to do for the program to be led by whoever might be the diabetes lead in the practice, or for one person to do it. We're not talking about large numbers, and there is a little bit to learn here in terms of the process and the selecting of patients. But the engaged patient is going to find this the most successful. So the person that you think will identify with the program, who is keen, who maybe has heard about it already, and who will be able to go through what I think we can all agree is quite a tough ask, well supported, but quite a tough thing to go through. It's the engaged people that have the best success with this, really. And I think people's knowledge of individuals is going to be far more valuable than the EMIS search. But nevertheless, it is there to identify the kind of cohort, and that's what was used to identify how many people would be invited per practice across NCL. I think that's everything. So, just also to mention, on the website there are some kind of resources there to share with patients. So we've got letter, text templates available, and the only kind of other issue will be offering them a standard 6-month and 12-month review in the practice. Next slide, please. So this is what I was mentioned. So across NCL, we have 500 places, and the allocation across the practices has been based on the number of eligible patients. There's a link here within the slide pack, and it will be on the website as well, to see which surgery and that you can find yourself on, and then how many low-calorie diet places each surgery has been allocated. We are talking about quite small numbers. I think every practice is below 10, and some practices just 1. Okay, and next slide. Just to mention there, the last point on there was about patients who drop out. So if they've started the program, I'm afraid that is their place taken. So if they've received the supplements and started the program, then that's their place taken. And if they do choose to drop out, then I'm afraid they can't be replaced. If it's that they start the conversation, don't actually start the program, and choose it and say that it's not for them, then that place is still available. But if they start, then unfortunately they can't be used. So next one. So the referrer's responsibilities. Although the EMIS search has tried to be quite comprehensive in identifying the eligible people, we do ask that every single referrer make sure that that person is actually eligible. In terms of coding, obviously that always falls down to our coding within EMIS. Things like retinopathy are often one of the pitfalls of things that may not be coded quite correctly, so worth always checking it. Hopefully that will be made clear in the process as well. There are obviously some risks and making people aware of the medication changes. So we're about to go through that. So I know that's probably going to be on the front of most people's minds. It certainly was on mine, but we'll go through that in just a second. Going through the medications with the patient and making sure that they're comfortable with the kind of changes that they might be able to make on their diabetes tablets, on perhaps their hypertensives, that's going to be really clear and will be something that we'll ask the referrer to go through with the patient. Okay, I think that's everything. Next slide, please. So, as we said, identifying the patients is going to be the most important part, and you will find that there are some people. I know that I've already had one person approach me even before this kind of scheme. I think it's quite exciting. It's received quite a lot of national press coverage, and certainly BBC documentaries from last year on things like fasting and the benefits of that make it quite a populist idea, which is quite nice. There's lots of other tempting things, making sure that they know that the products are all free of charge, you get a glucose meter, all of these kind of things, and that it's so supported that it's going to be there for a full year. There's some of the side effects for them to be aware of, things like hunger, headaches, actually cold peripheries. Those things do tend to get better and are almost always just a problem in the first week. So that instant shock of, oh, people must be starving constantly doesn't seem to be the case. Probably get used to it quite quickly, and fasting seems to be something that people adapt to really quite quickly.
Yeah.
So hopefully that is something that isn't an instant barrier, and certainly something that we can kind of talk them through, and shouldn't be something that puts people off. Next slide. So just to go through the referral process. So there's a template. So when you started the conversation with a patient, there's a template here which includes all of the referral criteria as well as a link there to the website. Hopefully it's quite summarized bullet points, but something that will guide the conversation through, just going through things like eligibility, firstly, HbA1c, height, weight, BMI, and then highlighting there the exclusion criteria. It will then take you through some of the basics in the conversation that have to be highlighted, and talking some of the adverse events, and then it will also guide you through some of the direction for medication changes, although all of that is gone through in quite a lot more detail in some of the resource packs that are on the website as well. Next slide. So after you've filled out the template, that will add some codes to the EMIS. And if that person does want to go through and you want to complete a referral, then there's a document available already in the EMIS as well, which will self-populate with some of the basic data, but not the longer entries. So there is a short amount to be entered there, but obviously it will pull through the basic details that we all kind of expect from these kind of referral forms. And then it's sent by email. Next slide, please. Okay, over to you, Eva.
Yeah, hi everyone. My name's Eva Morty. I'm the Deputy Head of Medicines Management, Haringey Borough. I'm the diabetes lead for the team, and I also have an interest in diabetes remission, so volunteered for this to talk you through the medicines changes. Next slide, please. So initiating medicines is everybody's comfortable with that. But stopping medicines, people are rather apprehensive about this. However, on the first day that the patient starts the TDR, you'll be telling them to stop blood pressure and blood glucose lowering agents. So stopping antihyperglycemic medication, it's reasonable because, you know, when you take medicines that, when you take food that raises your blood glucose, you need those medicines. But however, when you don't take those foods, you won't get those blood glucose spikes, and therefore there's no need for those medicines. Now, in the counterbalance study that informed the direct trial, within the first week on TDR, both blood glucose and blood pressure dropped quite substantially. Next slide, please. So here's the evidence from the counterbalance study. When medicines were stopped on the first day of TDR, blood glucose responded as in the graph on the left. It dropped quite dramatically within the first week, and this drop was sustained through to week 36. When you look at blood pressure on the right, the blue line is the systolic blood pressure and the orange is the diastolic blood pressure. And again, on the first day of TDR, despite all blood pressure agents being stopped, there was a drop in blood pressure right from week 1 through to week 36. Next slide, please. So what's the safety evidence from the direct trial? There were no adverse reactions in relation to hyperglycemia in the intervention group. However, when they looked at the cardiovascular events analysis at 2 years, the control group suffered from 2 cardiovascular accidents, 1 toe amputation, 1 aortic aneurysm rupture, and 1 sudden death. But in the intervention group, there was just 1 non-fatal MI in a participant who had not attended for a review at 12 or 24 months. So managing medication adjustments for blood glucose and blood pressure for this pilot has been modified to a concept.
If anyone has any samples, could you bring them to reception, please? Thank you.
In particular, in relation to blood pressure lowering agents, you'll be only asked to stop 1 agent, whereas in the direct study, they stopped all blood pressure medications on the first day. Next slide, please. So, medication adjustments for blood glucose lowering agents on the first day of TDR. When you refer the patient, you're going to have this discussion with them on that day. And depending on the number of agents that they're on, the number of agents they will stop differs. So if they're on 1 or 2 blood glucose lowering agents, you will be asking them to stop these agents, both of them, on the first day of TDR. If they're on 3 or more agents, you'll be asking them to stop 2 of them, leaving them only on metformin. Or if they're not on metformin, you'll be asking them to stay on an agent that is safe with TDR. So for instance, a DPP-4 inhibitor or pioglitazone. You'll be then putting this in writing for the patient and also for the low-calorie diet provider at the time of referral and passing this on to them. Do note that if a patient is on 3 or more agents and they're very keen to stop all on the first day of TDR, this is acceptable. However, the patient should be made aware that the glucose lowering agent may have to be restarted during the course of the program. And this is because on the direct trial, it was found that most people who are on 3 or more agents were less likely to achieve remission for their diabetes and more likely to go back onto medication. It doesn't mean that they might not benefit from the program. It just means that they might not achieve remission. However, they might achieve weight loss and other benefits from the program. Next slide, please. So which agents, glucose-lowering agents, are safe with TDR? Do note that patients on insulin are excluded from the pilot. So the first agent that's safe is metformin. And if you had to stop that and the patient required to restart any medication because their blood glucose started creeping up, that would be the first-line agent to restart. Other agents that are safe are pioglitazone and the DPP-4 inhibitors. Again, they can be restarted if a patient's blood glucose starts creeping up. But again, we would ask if the patient's not already on metformin, that you would start that one first. GLP-1 analogs are also safe with TDR. However, you'll be asked to stop those initially because of their high costs and their use may confound weight loss outcomes on the pilot. They can be restarted if necessary, but again, we would ask you to start metformin, pioglitazone, or a DPP-4 inhibitor first. Now, sulfonylureas and meglitinides are not safe with TDR, and this is because there's a high risk of them causing hypoglycemia. They stimulate insulin release regardless of blood glucose levels, and therefore are not safe with TDR. SGLT2 inhibitors are also not safe with TDR because of the risk of ketoacidosis. And the TDR is a ketogenic diet, so you put the patient at risk of getting ketoacidosis if they were on the TDR diet and this medication. And therefore, if the patient's blood glucose does start creeping up, you will be asked to consider the other agents which are safe first before initiating the sulfonylurea, meglitinide, or SGLT2 inhibitor. If you do initiate those items, then it precludes rescue TDR. Now, rescue TDR is after the 12-week treatment and the patient's introduced to food and their weight starts creeping up, then they will be entitled to a month's supply of rescue TDR. So if they do need this rescue and you started sulfonylurea or meglitinide's SGLT2 inhibitor, then they can't have the rescue TDR. Next slide, please. So here are some examples of blood glucose lowering, which blood glucose lowering agents to stop if a patient's on 3 or more agents. So the scenario is, first one is if they're on metformin, an SU or a DPP-4 inhibitor, you will stop the SU because it's not safe, and a DPP-4 inhibitor, and leave them just on metformin. So if they're on 3 agents, sulfonylurea, SGLT2 inhibitor, or GLP-1 analog, you would stop all of them because the SU is not safe, neither is the SGLT2 inhibitor. And remember, I said that regardless if a patient's on a GLP-1, that should be stopped in all instances. So the patient would remain on no agents. If a patient's on SU, SGLT2 inhibitor, and a DPP-4 inhibitor, then it's only the DPP-4 inhibitor that is safe with TDR, so you leave them on that. If they're on 4 agents, a DPP-4 inhibitor, pioglitazone, SGLT2 inhibitor, or GLP-1 analog, you would stop the SGLT2 inhibitor because it's not safe, the GLP-1, that because you always have to stop that, and then either leave them on a DPP-4 inhibitor or pioglitazone because those are safe with TDR. Next slide, please. Okay, so monitoring of blood glucose timelines. Between weeks 1 to week 4, the provider will be contacting the patient to get their blood pressure and blood glucose readings. The patient can also feed these readings up via the app to the provider. From weeks 5 to week 12, the provider will be contacting them at least every 2 weeks. And when they're not on TDR, then these readings will be collected from them, or they'll be contacted at least monthly. So your role will be at 6 months and 12 months to review the patient and do repeat HbA1c. So you'd have to set up a recall system to remind yourselves to do this for the patient. The provider will also be prompting the patient to remind you that this needs to be done. Next slide, please. Okay, so what are the provider's thresholds for communicating with you, the clinician? So if their blood glucose is under 50 millimoles per mole, no additional contact will be needed. But if it's between 15 and 19 over 2 sessions, you'll be contacted to tell you that this is what's going on with the patient. So if it's 20 millimoles per mole or higher, there'll be a same-day contact with the clinician and with the patient, and the patient will be urged to contact their GP. So how would you manage high glucose? First, you should explore the reason for the increase. Is it compliance? Are they eating other things? Were they ill? Or are they just highly resistant and not responding to TDR? Or are they resistant to their supportive medication? So you counsel the patient and then restart any medication that is safe with TDR. And again, you need to notify the provider and the patient in writing as to what the plan is and what you have done. Next slide, please. So as I said before, restarting glucose-lowering agents due to clinical need. This could either be identified by the provider and you'll be contacted, or you may pick this up after reviewing the patient's HbA1c at 6 months. You would start metformin first line, or if they're on metformin already, pioglitazone or DPP4 inhibitor. And finally, third line, a GLP-1 analog. But again, remember that this is not preferred because of its high cost and may confuse weight loss outcomes. So the above agents are all safe with TDR and could be restarted if clinically appropriate in line with NICE. And it's important to use your clinical judgment and check contraindications and cautions. Next slide, please. So for the agents that are not safe with TDR, sulfonylureas, meglitinides, and SGLT2 inhibitors, if you do need to start those, the patient must be told to stop TDR immediately, and the provider must be told. If the patient's already stopped a TDR and you identify that you need to start any of these agents, again, the provider must be told. And as I said before, restarting any of these agents precludes rescue TDR initiation, and therefore it's important to try and consider alternative agents first. If you feel that a patient needs to go on to insulin, then the patient should be told that they would have to come off the program, and you would have to let the provider know also. Next slide, please. Okay, so medication adjustments when starting TDR for blood pressure lowering agents. So remember that this guidance makes various assumptions which may not reflect the management of every patient. So it's important that you use your clinical judgment. Do remember that some agents may be used for managing blood pressure and another indication. For instance, ACE inhibitors in heart failure, agents used for neuropathy, angina, BPH, and migraines, and tamsulosin for BPH, and furosemide for edema. Next slide, please. Okay, so blood pressure adjustment discussions should be held at the time of referral. All new doses or the omission of doses should happen on the first day of TDR. The recommendations are, if the blood pressure is uncontrolled, you don't make any changes. If the blood pressure is controlled, being less than 140 over 90, then adjust just one blood pressure medication on the first day. You can use a remote review, that is self-reported blood pressure. Alternatively, the last clinic record blood pressure may be used, provided that no convenient lifestyle changes or medications that affect blood pressure had been started in that time, that the patient has not had a history of white coat hypertension, and this will be in patients who don't monitor their blood pressure at home and they only come to the clinics. Therefore, you don't really know what happens to their blood pressure whilst they're at home. And also provided that there's no concern that their blood pressure may have changed significantly since it was last measured. Now, in the circumstance that we are, people are working from home, they may be less mobile, less active, so it might be best to try and get a recent blood pressure before you make your decision. So note that all medication changes, including the absence, must be specified in writing for the patient and for the low-calorie diet provider. Do counsel the patient about symptoms of postural hypertension, fainting, lightheadedness, etc. as you have seen from the graph that their blood pressure can drop quite dramatically within the first week. And also maybe for patients who might not be on blood pressure medication, but could be borderline hypertensive, their blood pressure could drop too. So it's very important to think about that when you're counselling all the patients that they might experience postural hypertension. Next slide, please. So we're going to talk about agents being used specifically and solely for blood pressure management, and these should be the priority for adjustment. So identify these agents and check the patient's records and confirm with the patient that that medication was initiated specifically only for blood pressure management. So you will stop the agent that would have been added last in accordance to current NICE guidance. Next slide, please. So this is a proposed stopping order for agents that are only being used for blood pressure. So you will stop the spironolactone, an alpha blocker or beta blocker first. Then you will stop a thiazide diuretic or a calcium channel blocker next, depending on the order in which they were started. And finally, an ACE inhibitor or an ARB that would be stopped last. Next slide, please. So this is for agents not being specifically or solely used for managing blood pressure. So if the patient's taking agents which affect their blood pressure but are being used for other indications, you would have to use your clinical judgment, a shared decision-making approach, and take into account what their current blood pressure actually is. You could cautiously reduce the dose rather than stop it. You can consider arranging an early review to monitor the clinical response in relation to the specific indication for which the medication was started, or maybe have an agreement with the patient that they would contact you, to let you know how they're getting on if they should have any issues. And in some circumstances, it might be reasonable not to adjust these agents, but rather carefully monitor and respond accordingly to any changes. Next slide, please. So these are the provider's threshold for communicating with you in relation to blood pressure changes. So if the patient's blood pressure is 90/60 or lower, or they're experiencing postural symptoms, the provider will be contacting you and the patient on the same day, specifically if the symptoms are interfering with daily activities. The patient will also be told to get in touch with you on the same day. Between 90/60 and 159/99, there'll be no action. 160/100 to 179/119 on 2 sessions, the provider will contact you. And if it's 180/120 or higher, the provider again will contact you on the same day. They will contact the patient and encourage the patient to contact you. So for avoidance of doubt, if blood pressure reading fits in 2 of the red categories described here, for instance, 181/118, action should be taken in line with the category prompting the most rapid response. And in this case, it will be same day contact with yourself, the patient, and the patient will be asked to contact you. Next slide, please. So here are examples of where at least one agent is being used solely for blood pressure. So if the patient's only on ramipril, you would just stop that, ask the patient to stop that on the first day of TDR. If they're on ramipril and amlodipine, then you would stop amlodipine on the first day of TDR, as amlodipine would have been added last in accordance to NICE guidance. If they're on amlodipine for blood pressure, ramipril for previous MI, indapamide for blood pressure only, and bisoprolol, here you would stop the indapamide, or alternatively you could lower the amlodipine dose. Although according to NICE, bisoprolol would have been added for the management of hypertension, Here it's being used for another indication. Therefore, excluding bisoprolol, indapamide would have been added last in accordance to NICE, and therefore you should be stopping indapamide. Next slide, please. So here are some examples where no agents are being used solely for blood pressure, and the blood pressure is controlled at the time of referral. So for instance, ramipril 10 milligrams for neuropathy. Here you would reduce the dose of ramipril rather than just stop it because it's being used for something else. But then again, you know, the patient might still experience hypotension when they start TDR. If the patient's on propranolol and doxazosine, so propranolol for migraine prophylaxis and doxazosine for BPH, discuss the options of balancing potential increase in migraine frequency and LUT symptoms against the risk of hypertension on TDR with the patient. Here, given that the doses are low, it might be reasonable not to make any changes, but carefully monitor and respond accordingly. And if a medication adjustment has happened, it's advisable to arrange a review or make an arrangement with the patient where they can contact you if their symptoms worsen. The third box is if a patient's on ramipril, furosemide, and bisoprolol for heart failure, this would need a very cautious approach. It might be inadvisable to suddenly stop an agent unless you have a strong clinical reason to do so. Carefully reduce the dose of one agent and use your clinical judgment and the shared decision making, you know, explaining to the patient what might happen or when they need to contact you, arrange an early review, including an assessment of furosemide, especially if you did adjust that. Next slide, please. Oh, I just wanted to say also that if a patient has like severe heart failure, you know, they're excluded from the pilot, and therefore you probably wouldn't be doing that. And because you have very few patients that you're going to be working with, it might be wise to exclude such patients in this pilot at this time. Next slide, please. Thank you. Okay, so adjustments for blood pressure lowering agents. If the blood pressure is too low, patients experiencing postural symptoms, or you've been contacted by the provider for this reason, you would follow the same process as outlined in accordance to blood pressure lowering agents, which is stop the agent that was added last. Adjust the agents that are specifically and solely initiated for the management of blood pressure rather than other agents for other indicators. If the blood pressure is too high and it triggers the threshold where intensification of medication is required, you use your clinical judgment and restart medication or uptitrate whatever they're on at the time. Assess whether any previously adjusted medication was for other indications first, and maybe those are the ones that you should rather restart or uptitrate first. And just follow NICE guidance in restarting antihypertensive medication. Next slide, please. So this is my last slide. For all prescribing, you need to, for all the medications that the patient's on, you need to be asking yourself, will the patient need a dose adjustment if there's a major dietary change or weight change? It's the responsibility of the referrer to make sure that processes are in place for any applicable medicines to be adjusted. If the patient is under other services, such as a specialist clinic, then you would need to hold a discussion with such services to establish the feasibility, who will be responsible for appropriate reviews of the patient and dose adjustments. So I think as you are just working with very few numbers right now, it may be best to exclude such patients that would cause a lot of involvement by other clinicians. So this is just a table of the kind of medicines that may be affected by weight loss or dietary changes. So oral medicines, warfarin, DOAC, digoxin, phenytoin, cyclosporin, antifungals and long-term antibiotics. And for parentally administered medicines, we have low molecular weight heparin, infliximab, and again, long-term antibiotic therapy. That's it. Thank you.
Okay. So back to me. The next slide, please. Just to let you know how ICS contacts the GP surgeries. So we're going to, it comes in through the generic practice email. We've got a link there to the Excel sheet that's got a summary of all of the emails that we have listed for the practices. It is a kind of a hope that we'll be able to get this to come directly into EMIS docs at some point. We're not sure quite when that might be on the horizon, but for now it's going to be through the practice email. The kind of notifications will be referral received, discharge, if there's any kind of complications, and some of those non-urgent, more clinical things will be coming through email. So notifications of adverse events, that kind of thing. Next slide, please. And then the important other part, after somebody's been accepted and the referral's been made, there are 3 things to put onto the EMIS record. The first one to say is to code it within the problems list. Now, there is a code for a low-calorie diet, so we'd ask that you put that in their problem list, partly because that just makes it explicitly clear to everybody else on the record, but also it will share across the borough with the healthy intent data sharing, and it should be then available to secondary care as well to make sure that if there was anything else that they needed to present to secondary care for, it would be visible. So that's would be ideal. Next thing to say is when you're making medication changes, we ask that the reason box be filled in with why you might be stopping, for example, in that they're an antihypertensive to just stay starting low calorie diet program and then to end a medication. And that may also be relevant to tell the local pharmacist. So if on one of the prescriptions, you could write, like here, the example is metformin, that the pharmacy text has been edited to say medication regime started as part of low-cal diet program, rather than surprising somebody that you've just stopped 2 out of 3 of their diabetes medicines on someone that they probably know quite well. I think that's everything I have to say there on updating the record. Next slide is just to show that we've got quite a lot of resources. So obviously it's all quite new for all of us, but so exciting to be able to offer it. The website should have a copy of this discussion. It should have the practice allocation. There'll be the templates for the letters and text, patient information, and links to the ICS website. If there's any queries, you've got our contact details there. Obviously, clinical things, please do send them to me. Practical things, I'm going to be useless, so Claire's your person. But if there's anything, please just let us know. If there's kind of specific clinical questions, happy to take those forwards. And if I'm unable to answer them, which I'm sure is likely, as I said before, we've got a national group of the clinical leads across the pilots who get together and discuss these kind of things as well. And that's got input from NHS England. So hopefully we'll be able to get back to you quite quickly with advice. Next slide. So just before we mention Q&A, just to say, if anybody did arrive late or hasn't done so already, if you could pop in the chat which practice you're representing, just to make sure that we get a good record of who attended for the backfill when we go through. So do pop that in the chat. And then I think that may be everything, and we'll open up to Q&A. Thank you, Deb. So Nick, you've got, can we refer patients from today? Yes, we can. It's all open. As always with these things, it's appreciated if you do make sure that the conversation with the patient's had and you feel it's the right person, and then don't inundate the service with a whole load of people, but absolutely completely open to referrals from now. And I just saw a hand. Oh, gone.
Just catching up, Carl, on some of the questions that have come up in the chat.
No problem. David, you've just popped your hand up. Do you want to come in?
Sorry, I'm too slow typing. It was just a quick, thank you very much. That was a very thorough presentation, feeling a bit overwhelmed. Just within the, you gave some indicated numbers of patients there might be, and you showed Central 2 PCN, and I saw River Place, my practice, had 6 patients on there, but other practices had less. And I just wondered how is that calculated? What does that mean? Is that an expectation that for the service to work and be funded properly, you do need these 6 referrals from River Place? Tell me a little bit more about that and how it's come about.
Claire, do you want to?
Yeah, so
that?
the patient numbers have been divvied up depending on how many eligible patients there are per practice to make it as fair as possible. So practices with larger number of allocated places, that would be because they have more potential eligible patients. Sorry, David, your other question was around the use of those places. Just to flag that, obviously, you can use as many of those that you've been allocated as you wish. If there are unused places, say, for example, patients aren't interested in taking it up at your practice, we will reallocate those spaces to other practices who may have been given fewer places but have more patients who are interested. So we will keep, myself alongside Priscilla from ICS, we'll do a regular review of referrals and which practices they're coming in from. And if we see that for some practices there's low levels of engagement, we will get in touch with that practice initially to discuss, and then if appropriate, reallocate those places to other practices where there may be higher levels of engagement.
Sorry, Claire, can I just come back? So just to understand that, I mean, I must say, it's fantastic to have this. I was 10 minutes late because I was on the NCL COVID vaccination programme webinar, and I guess for me, and I'm sure for lots of other people, the next 3 months looks to me to be COVID vaccination.
Yes.
And it's hard to see beyond that.
Yeah.
So I must say I missed the bit maybe where you said about the eligibility, and I don't want to drag everyone to hear that all again if you've done it already, but also just thinking, you know, when I go back to discuss this with my practice team, I think when I say, guys, there's a really exciting opportunity for low calorie diet, they're going to be saying, whoa, could we just leave this till a few months and get through this next very difficult? I mean, there's also the second wave anticipated with COVID. I think timing is one of those things, but what sort of time frame have we got within this? Because obviously this is a resource that's offered to us, and I'm aware if we don't use it, then it could be lost, and that would be terrible.
Yeah, absolutely. So it is a 2-year pilot. So don't worry about feeling pressure to refer lots of patients now. You've got the full 2 years. And completely appreciate that practices are going to be exceptionally busy over the next few months, and that this may take a bit of a back seat. So don't worry about having to use those places up straight away. We will give a lot of breathing space to practices before you start using up those places. I think also just to note from a question from one of the other training sessions is that we're very aware that Christmas is coming up, and that's obviously a really hard time to be doing a low calorie diet pilot. So it may be that you may speak to patients this side of Christmas or not. It might be that they want to delay and have that conversation in January. Typically January is that month of the year where everyone wants to get fit. So just to be mindful that it may be there are more appropriate times of the year to make those referrals than right now.
Excellent, thank you.
Just looking up through some of the other questions, I think someone's asked about the consultation template, and yes, that should be on everybody's practice systems. So Hillary's asked, when patients sign up, how will patients get the deliveries? Are you all up front after they express their preference on a regular interval for delivery? Naomi, I'm not sure if that's been answered lower down in the chat.
Yeah, it has been answered, and they get everything up front. So it all gets sent, the full 12 weeks worth of TDR and their self-monitoring kit gets sent straight after their initial assessment before their first sort of one-to-one session on the TDR.
Brilliant, thank you. Just having one more look. Another look. Next, we've already covered that. Refer patients from today if you would like to. Yes, we have gone live. Copy of the slides will all be sent, so we'll send a really full follow-up email after this with a copy of the slides, that patient allocation profile, and also a list of your generic email addresses that we will be using. So if you have a quick look at that and think, oh, that's not the right email address for us, please let us know and we will update the records to make sure we're sending everything to the right place. Joan has asked how we communicate with the provider. And I think Priscilla's responded with her email address. So Priscilla will be our local point of contact across NCL, which is brilliant. So please do get in touch with her if you've got any specific provider questions. Just looking through the chat. Okay. F has covered Christmas as well. It's definitely a topical issue. Someone's asked how soon after the referral should the patient start to be contacted, and Naomi's answered within 5 working days. And Naomi, there's a time limit as well, isn't there, between the initial assessment with the patient, but we will try to be flexible with that around Christmas.
Yeah, originally the sort of guidance from NHS England was that post-referral we would need to complete their initial assessment within 30 days, but with Christmas kind of looming in all that, there was some flexibility given to that, and it can now be within 90 days. So we'll give them the choice of when they want to start, but it kind of has to be done within sort of those 90 day time period. So quite a lot of flexibility with that based on what the patients want to do. I suppose it's looking at when is the best time for them to start. So we'll be having those kind of conversations with them when we have those initial assessments and booking calls.
Brilliant, thank you. And Deb has asked, how quickly do ICS contact the GP if the patient disappears off the radar? So I'm assuming that's if they're not engaging through the app or through the one-to-one telephone calls.
Yeah, so I mean, we have kind of a process where we will attempt to contact at least three times before they're kind of discharged, I suppose. And depending on where they are in the programme will depend on kind of how quickly that's done. So obviously if they're in the total diet replacement phase, then that's a very short period of time. Whereas obviously as they move through, there's a little bit more flexibility with that. So you would get those contact points that were listed when they were discharged, you would get notification at that point, which will be quite quickly in the TDR stage. So hopefully that answers that question.
So they're not on their meds anymore, so there would be a concern, I think, if they disappear off the radar.
Yeah.
Thanks, Deb. Any other questions? I think we've covered everything, all the questions in the chat. So if anybody has any more, say so now. Raise your hand or add it to the chat if you prefer. I can't see any hands, so I think we'll draw it to a close there, if that's okay. And obviously all of our contact details will be shared, so feel free to get in touch if you think of any questions afterwards. Okay, thank you for joining, everybody, and thanks to Carl for chairing, and to Priscilla and Naomi and Effa for doing your bits as well. Thank you.